This presentation aims to provide the audience with a general overview of the recognized dental specialty dedicated to the diagnosis and management of orofacial pain. This presentation is provided by the American Academy of Orofacial Pain, and if you'd like to learn more about this new dental specialty, please visit our website at aaop.org. So what is orofacial pain? Orofacial pain is a dental specialty focused on the diagnosis, management, and treatment of pain disorders in the jaw, mouth, face, head, and neck. These anatomical regions contain an array of diverse structures ranging from the dental pulp to the meninges of the brain. Patients suffering from an orofacial pain will present to a variety of clinicians, including headache physicians, dentists, maxillofacial surgeons, otorhinolaryngologists, and neurologists. Despite this apparent diversity, the underlying system that unifies all of these anatomical structures is the trigeminal sensory complex, in which impulses from the head and neck are conveyed by the branches of the trigeminal and upper cervical nerves into the trigeminal sensory nucleus in the brainstem. Due to the diversity and complexity of orofacial pain conditions, it's led to the recognition of the need for a specialized field of dentistry and for collaboration among multiple fields of medicine to improve care for patients afflicted with these conditions. And finally, in March 2020, the National Commission on Recognition of Dental Specialties and the certifying boards officially recognized orofacial pain as a dental specialty. Did you know that 1 out of 6 individuals will suffer from orofacial pain? It has been estimated that the prevalence of orofacial pain conditions in the general population ranges from between 10 to 20%. These conditions can oftentimes cause recurrent or chronic pain, which can have a significant impact on the quality of life of patients, limiting their functional status and resulting in substantial healthcare costs and loss of productivity. Chronic pain, which is defined as pain lasting more than 3 months, is a debilitating condition that affects 20% of the population worldwide. Addressing chronic pain and improving the lives of people living with a pain condition becomes a critical public health priority. In the US, an estimated 50 million adults experience chronic pain, resulting in a total financial cost of pain to society, which combines the healthcare costs estimates and 3 productivity estimates, ranging from $560 to $635 billion. In a European population-based study, 20% suffered from chronic pain. And after back pain and joint pain, pain in the head and neck was the next most common condition, affecting 1 out of every 4 patients with chronic pain. Therefore, orofacial pain is a prevalent and disabling condition. The management of orofacial pain must be grounded on evidence-based practices and requires a collaborative effort between various healthcare professionals to ultimately improve patients' lives. It's been estimated that the economic burden for the diagnosis and treatment of orofacial pain and TMD is around $100 billion a year. So what are the most common orofacial pain conditions? Orofacial pain can be broadly categorized in 4 distinct categories: odontogenic pain, musculoskeletal pain, or temporomandibular disorders, which are commonly referred to as TMJ, neurovascular pain or headaches, and neuropathic pain. First, we'll take a look at odontogenic pain. Odontogenic pain is the most common cause for acute orofacial pain, and it's characterized by pain that arises from either the pulp or the periodontal tissues, which is commonly referred to as a toothache. Generally, odontogenic pain, either from the pulp or the periodontium, have an infectious and inflammatory etiology and requires a dental procedure such as a extraction or root canal to manage. However, it's crucial for the clinician to understand that in some instances, dental pain can arise from other sources that are non-odontogenic. For example, referred pain from adjacent structures. It's well known that sinus infections can lead to dental pain in the maxillary teeth, and similarly, the presence of trigger points in the masticatory muscles can cause referred pain to the dental structures. Conversely, dental pathology can also refer to other anatomical regions. Therefore, when diagnosing dental pain, it's important for the clinician to recognize and understand that the source of pain is not always the same as the site of the patient's pain. After odontogenic pain, the second most prevalent orofacial pain conditions are temporomandibular disorders, also known as TMDs. TMDs encompass a group of musculoskeletal and neuromuscular conditions that involve the temporomandibular joints, also known as the TMJs, the masticatory muscles, and all other associated tissues. They affect approximately 5 to 12% of the population, with an annual cost estimated at about $4 billion. About half to two-thirds of those with TMJ disorders will seek treatment. Temporomandibular disorder is the most prevalent type of chronic orofacial pain. It's noteworthy to mention that chronic temporomandibular disorders seldom appear as an isolated complaint and are usually comorbid with other conditions. United States Congress and the National Institute of Health list 10 conditions as chronic overlapping conditions, or COPCs, including temporomandibular disorders, chronic fatigue syndrome, irritable bowel syndrome, fibromyalgia, chronic tension type headaches, chronic migraine headaches, and chronic lower back pain, among others. In these conditions, there may not always be actual tissue damage or lesions at the somatosensory nervous system, and similarly, the term neuropathic pain does not fully capture the patient's pain experience. A proposed third mechanistic pain descriptor, nocioplastic pain, was added to IASP terminology in 2017, and it may better capture features that we see in COPCs. Nocioplastic pain is then defined as pain that arises from altered nociception, but without clear evidence of tissue damage or somatosensory system lesion or disease. Temporomandibular disorders present a multifactorial etiology, and these etiological factors can be further subdivided into initiating factors if they cause the onset of TMD, predisposing factors when they increase the risk of TMD, and perpetuating factors when they interfere with the healing or enhance the progression of the disease. Moreover, depending on the circumstances, an individual factor can play a role in each category. These etiological factors comprise several categories, including trauma, which can be further divided into 3 types: direct trauma, which is the result of a direct force to its structures; indirect trauma, when the force received is not in direct contact, for example, such as a whiplash injury; and lastly, microtraumas caused by oroparafunctional habits, such as clenching and grinding of the teeth. Secondly, anatomical factors related to occlusion and craniofacial morphology have been long debated within the dental community. However, the current evidence suggests that the influence of occlusion in the onset and development of TMD is very low. On the other hand, in some cases, occlusal changes can be the consequence of the disease and not the cause. For example, the development of an anterior open bite secondary to the degenerative joint disease affecting temporomandibular joint. Third, systemic conditions that involve degenerative, endocrine, infectious, rheumatologic, and vascular disorders can influence local TMDs and should generally be managed in cooperation with the patient's primary care physician or a medical specialist. Fourth, there's a growing body of evidence in regard to the genetic susceptibility for TMDs. Certain genes, such as the COMT gene, have been associated with the risk of developing TMDs. Lastly, psychosocial factors such as anxiety and depression can impact the patient's capacity to function adaptively. Patients with TMDs have been demonstrated to have a negative mood, elevated perceived stress, and pain catastrophizing. Temporomandibular disorders can be classified into 4 major groups based on the expanded TMD taxonomy classification. First, disorders that affect the temporomandibular joint, including arthralgia, disc disorders such as disc displacement, or a degenerative joint disease such as osteoarthritis. Secondly, we have groups of disorders that affect the muscles of mastication, such as myalgia or myofascial pain. Headaches attributed to TMDs, as described in the International Classification of Headache Disorders, or ICHD-3, are characterized by the presence of pain in the temple area that's aggravated by jaw function. The final category includes conditions that are associated with changes to the surrounding structures that affect the function of the TMJ, such as in the case of coronoid hyperplasia. The management goals for TMDs are like those for other orthopedic conditions and include decreasing pain, decreasing adverse loading, restoring function, and resuming normal daily activities. It's been demonstrated that between 85 to 90% of patients will achieve good TMD symptom relief with conservative therapy at 6 to 12 months, lasting between 2 to 10 years. This conservative therapy includes many modalities such as patient education and self-management, with soft diet and thermotherapy, and pain-free jaw function. Biobehavioral therapy is a very useful modality targeting oral parafunctional habits such as bruxism, which is defined as the involuntary activity of clenching or grinding the teeth or bracing the jaw muscles. Pharmacologic therapy, including analgesics, anti-inflammatory medications, muscle relaxants, antidepressants, and others. Physical therapy, which may include exercises and postural training, or ultrasound and iontophoresis and dry needling. Last but not least, occlusal appliance therapy is used to distribute occlusal forces, preventing dental wear and reducing bruxism. Only in select cases of articular disorders, TMJ surgeries such as arthrocentesis or arthroscopy, or even total joint replacement should be considered. Always, however, in combination with preoperative and postoperative conservative treatments, as we just described. Next, we have neurovascular pains. Neurovascular pains arise from the interaction between the nervous and vascular system, and they're often associated to migraines and trigeminal autonomic cephalalgias. These are primary headaches, which are disorders not attributed to any other cause. Clinicians who treat orofacial pain should become well-versed in primary headache disorders, since the prevalence of migraine in patients with a TMD diagnosis is 40%, and accordingly, higher than in the general population. Furthermore, as described in the first edition of the International Classification of Orofacial Pain, published in 2020, primary headaches can also present with facial or oral patterns, including toothaches, even if the patient does not experience pain elsewhere in the head. Some of these conditions include orofacial migraine, tension-type orofacial pain, trigeminal autonomic orofacial pain, and neurovascular orofacial pain. And finally, we have neuropathic pains. Neuropathic pains arise from a lesion in the peripheral or central somatosensory system, and clinicians need to recognize and understand that neuropathic pain can mimic odontogenic pain. As mentioned previously in this presentation, the clinician needs to understand and recognize that not all toothaches are of odontogenic origin. Persistent idiopathic dental alveolar pain or post-traumatic trigeminal neuropathic pain are examples of neuropathic pain that can present as dental pain. Early detection of non-odontogenic pain becomes paramount to avoiding unnecessary or invasive treatment. Neuropathic orofacial pain can present as episodic or constant and encompasses multiple conditions, including trigeminal neuralgia, which is characterized by electric shock-like pain following the distribution of the trigeminal nerves. Burning mouth syndrome is another example of neuropathic pain, which is poorly understood, but can present with a prevalence of around 0.5% in the general population. Similarly to other orofacial pain conditions, the management of neuropathic orofacial pain often requires a multidimensional and multidisciplinary approach. So to conclude this presentation, the diversity and complexity of these conditions have led to the recognition of the need for a specialty in orofacial pain. The specialty of orofacial pain is dedicated to the evidence-based understanding of the underlying pathophysiology, etiology, prevention, and treatment of orofacial pain disorders, and improving access to multidisciplinary patient care.